Good evening. My name is Amy. I'm a Community Education Coordinator for Boulder Community Health. Welcome to tonight's lecture, Hysterectomy Myths You Should Stop Believing. The lecture portion will last about 45 minutes, and afterwards we'll use the remaining time to answer any of your questions. Please type your short, general question in the chat box below the video on your screen, and we will take as many as we can. On behalf of Boulder Community Health, I'd like to introduce tonight's speaker, Dr. Jeremiah McNamara. Dr. McNamara is a board-certified obstetrician gynecologist who earned his medical degree from Michigan State University's College of Human Medicine and completed his OB-GYN residency training at the University of Wisconsin. He provides valuable expertise in gynecological surgical specialties, such as robotic-assisted hysterectomy. He also specializes in a range of treatments to address pelvic floor weakness, prolapse, and associated issues such as pain and incontinence. He sees patients at Boulder Women's Care here at Foothills Hospital. Welcome to Dr. McNamara.
Thank you, Amy. Thanks everyone for tuning in to this talk. We were just discussing it's been since 2012 was the last time we had a lecture on this topic for the community, which I think is a little crazy. The surgery has come a long way, a lot to talk about. So I'm happy that we are doing this one. I think this is going to be a really important and useful talk for the community. Am I still good?
I'm not getting your slides. You could hit the presentation. That'll put them up.
Let me get my slides up. All right, cool. So in terms of disclosures, I am a bit of a consultant for Medtronic to talk to them about some of their surgical devices and stuff that we use in the OR, just to disclose that. And I want to say in the beginning, happy Pride Month. It is June. And this talk, I do want to acknowledge that in the way that I talk about these topics in this next little bit, I will use the term women. But I want to acknowledge that the experience of transgender folks in this topic is extremely important and relevant for those people as well. So I am an OB-GYN here at BCH. That means that I do the OB part and deliver babies and take care of women during pregnancy, and also do a lot of gynecologic care, surgical care for women as well. So in terms of an agenda and what I'd just like to talk about, I want to make sure we have some time to talk about questions, because I think part of my impetus for giving this talk was just the experience that patients in the office have so many questions about this surgery and don't have a good understanding because it's not out there about like, what is this all about? What's the surgery really like? So I tried to really bring up and answer questions in the way that I put these slides together, but I want to move through these important things so that we can also answer questions, because that idea is kind of something that really prompted me to want to do this topic in the first place. So a little bit of introduction and brief history of what's going on with this surgery, some of the common reasons that we do hysterectomy. I do really want to talk about other options other than doing the surgery, which I think is super important to talk about. There are many effective options that are not having this surgery, and I'm just as much an advocate for those options as well, and those are an extremely important thing to talk about, along with the option of having a bigger surgery like a hysterectomy. And then I do just want to try to walk through as much as I can how I describe this surgery and this experience, the experience of having the surgery, to you guys in the office. I want to give that to you briefly here so you kind of hear my explanation of like, what is it like to do this, you know, in the office before, in the hospital, and what's the recovery like, which I know is a huge question on people's minds. A little bit about outcomes and complications that can happen, which are obviously super important to talk about with any surgery. And then specifically just trying to address some of the most common questions that I get asked in the office about this. But I do just want to start off by giving a couple comments just about the whole topic at hand. I wanted to talk about hysterectomy because this is indeed one of the most, if not the most important procedure I think that gynecologists do every day. It's important not only because it's done often, and it is done often, and for good reason. It really is an extremely effective solution to some really common, really debilitating problems. And so it is done a lot because it benefits a lot of patients. But it's also, I think, a really important procedure for us and the patient because it's a big deal to remove the uterus, and I mean that medically and emotionally. The uterus is a very special organ, and I mean that in many senses. We are all here due to the good action of a uterus along the way. And even though I don't have one myself, I do truly have an appreciation for how difficult of a decision it is to think about removing your uterus. However beneficial that may be for other aspects of one's life as they get into this decision-making process of removing it, it's a big deal, and there is a sadness in there in thinking about this surgery, which I do want to acknowledge and honor, truly. So I want to say that up front. I'm not interested really in giving a talk that like celebrates the great surgery of hysterectomy necessarily. That's not my goal. But I would be lying if I didn't say that I have just had countless patients whose lives have been significantly improved by what the surgery has to offer them in terms of the problems that they're having. So my goal is really just to provide some clarity around the procedure, to answer common questions that people have and want to ask the surgeon at the dinner party about this whole thing, so that patients can really just feel more empowered and more steady in their decision-making about these problems, these really common problems that start to lead us to talk about the surgery. And as I said, I do want to mention, although we don't have time to dive into the intricacies of all of the alternatives for all of the problems, I really will mention them, and they're super important because they exist and they really can work really well. And it's really important to talk about the alternatives to having a big surgery, for sure. So I don't want to be too dorky about medical history or spend too much time on it, but hysterectomy, as you might imagine, has been around for a long time and was a real mess for a long time. The earliest hysterectomies were done in like 160 AD. It is mentioned for the first time. The first true hysterectomy was done in 1843 by that English gentleman right there. There was a long, rough period in all surgery that actually really extended into the era when a lot of our grandmothers and great-grandmothers had surgeries, which is are a lot of, to some degree, a lot of the stories that patients still sometimes only have that to carry into their expectations about what hysterectomy is like. And so, indeed, the old days, there was a time of no antibiotics or anesthesia, and that was not a good time to have surgery. But even in the 60s and 70s and 80s, when the safety had really improved a lot, the surgical experience was way different than it is these days. How the surgeries were done, all of our grandmothers having their ovaries removed at random times without much explanation. The recovery was much different. So it's really important to talk about like what the surgery is like now. And to be honest, even compared to 2012, the last time we had this lecture, a ton has changed in how the surgery is, how the recovery is. So there was a long, dark time for surgery. The first laparoscopic hysterectomy and the switch to doing things laparoscopically instead of using an open incision was a big deal in surgery, and that began in the late 80s and 90s when laparoscopy really started to take over. And we are indeed kind of in another big transition time in surgery and for hysterectomy, in so much as robotics is being used more and more. And like the technology that was kind of being initiated with laparoscopy has taken amazing leaps with the advent of robotics and a number of really beneficial things for the surgeon and the patient these days. So hysterectomy is very common. The last clear explanation of total surgeries in the United States that I could find some information about, the last time that I was able to look at this, hysterectomy number 8 nationally amongst men and women in terms of surgeries done every day in this country. And indeed, the second most common surgery in total done on women every day in the US. And indeed, other than knees, which occupies the number 1 spot, the most common surgery done by gynecologists for women on their reproductive organs. And it's true that a lot of them are done and need to be done for women across the course of their life. This graph from the CDC describes that, thankfully, hysterectomies are done rather rarely for this age group from 18 to 44. There is, unsurprisingly, a big jump to more and more hysterectomies being done once women are 45 and older. The problematic time period there is perimenopause, largely, and the fact that abnormal bleeding and uterine fibroids tend to really show up and present themselves for women really in their 4th decade, and there's an awful lot of hysterectomies that are talked about and done weirdly and paradoxically just in the last many years before a woman actually goes through menopause and bleeding stops naturally. So it is interesting, and kind of unfortunate that way that we really need to do some of these procedures at that time frame. But there's a big jump in the late 40s. And then the reason that there are even jumps from that 45 to 64 bracket into women in their 60s and 70s and older has a lot to do with prolapse and pelvic floor weakness and hysterectomies that are done for uterine prolapse, which is indeed very, very common. So when we just talk about indications for hysterectomies in general, just when you talk about the whole gamut, these percentages don't add up to 100 because they overlap with each other, as in women who have fibroids very often have abnormal bleeding and pain, et cetera. But to rank them, uterine fibroids, which I don't know that, I think the general public might not guess that right away, that uterine fibroids would be like the most common indication for hysterectomy, but that's true. Fibroids are very, very common. They tend to run in families. They can cause a lot of bothersome symptoms in terms of the size of the fibroids pushing on things, which we call bulk symptoms, or causing abnormal bleeding. So fibroids, very, very common. Abnormal bleeding, very, very common. And then I would say these other categories of pain, which endometriosis is not the only entity that causes pelvic pain and gynecologic pain in women, but it is the most common cause of that. Prolapse, and then cancer and precancer surgeries. So although I think there's a lot of things that are going well with the surgery of hysterectomy and its evolution, it is, I think, happily true that there are actually relatively less hysterectomies going on over time in this most recent decade or two, largely because of what we're going to talk about next, that alternatives to hysterectomy have come a long way as well and are much more understood, available, effective, and so that less women are actually needing hysterectomies than they were before we had these other options. So I do want to kind of go through those common indications quickly and talk about alternatives that are there that we're kind of balancing with the idea of having surgery. So for abnormal bleeding, heavy bleeding, and this is very brief. This is an entire conversation in itself, which I have all the time with women about abnormal heavy bleeding. What are our options? I think it's super important every time to go through all of the options that range from the least invasive to the most invasive, and really talk about everything that's in that spectrum, because they're all legitimate and they might all be like the right choice for that patient. So to go through that very briefly for bleeding, there are way down at the non-interventional end of things is doing nothing. That's not always the reason that patients come to see us in the office with heavy bleeding, because they're interested in doing nothing about their bleeding. But we kind of talk about what needs to be done, what's safe, like what's bothering you the most in life. But right above doing nothing is the idea of non-hormonal medications for heavy bleeding. So not even birth control pills and all the hormones, but ways that we can use non-steroidals to improve bleeding, which is a real thing. And then also there is really one prominent non-hormonal medication that treats heavy bleeding and heavy periods, which is called Lystida or tranexamic acid. It's indeed not a hormone. Above that, there are hormonal therapies, which I know not everyone wants to be on exogenous hormones, and I truly understand that. But there are effective, very effective hormonal therapies for heavy periods and heavy bleeding and irregular bleeding. So that can be many things. It can be birth control pills. It can be long-acting reversible options, as we say, like a hormone releasing IUDs or the implant that goes in your arm. So really some very effective options that last for years and years. And then there is also an endometrial ablation, which is a newer, not exactly new at this point, but a newer procedure which has indeed allowed many women to not have a hysterectomy, to have a minor outpatient procedure that for a lot of people has the same impact as a hysterectomy in a lot of situations, which is the complete lack of periods after having that procedure. So an ablation, very briefly, is an outpatient procedure, no incisions in your belly, where this is done in the OR, you get some sedation, but there's a device that goes into the uterus and just spreads out and touches all of the surfaces of the endometrial lining inside the uterus, the whole apparatus that bleeds, that can bleed in the uterus. And it very superficially burns that lining, which sounds scary, but that's done very superficially. And it does make that lining ineffective. Can't bleed, doesn't bleed. For about 65-70% of women, we have no more periods at all after an ablation. So ablations are not perfect for all people in all situations, but indeed a less invasive option that really has some pretty great outcomes for heavy bleeding. For uterine fibroids, a lot of really interesting options for fibroids that are not necessarily hysterectomy. There is indeed a conversation about just watching fibroids, just monitoring their growth. It's not true that all women that have fibroids must have a hysterectomy as a matter of cause. That's not true. So there's a discussion about maybe just monitoring them. There are some hormonal therapies that can be helpful for women with fibroids in terms of improving symptoms and kind of shrinking the size of fibroids, even though we don't really have a good lasting medicine that just shrinks fibroids and really solves that problem. I wish we did. But there are also some other procedures to get into the surgery side of things other than hysterectomy for women with fibroids. So there's a fascinating and also rather new procedure called uterine fibroid embolization that's done by interventional radiologists in the hospital, where this is done in a way that's kind of similar to you could think of it like similar to a heart cath, where you have a small incision in your groin. The cardiologists, when they're doing a heart cath, are wiggling a wire up to a blocked blood vessel in the heart and opening the vessel on purpose, saving the person's life. With fibroids, the radiologists have a similar but opposite procedure where they make that same incision in your groin. This is definitely an outpatient procedure. They wiggle a wire to the arteries that feed those fibroids, and they block them on purpose. They embolize them. And so there's no more blood supply to the fibroids, and they actually die and shrink. And that, I'm sure, sounds pretty wild, but that is actually can be a pretty great procedure for some women in some situations with fibroids and really improve bleeding and the size of the fibroids. There is a laparoscopic procedure called radiofrequency ablation, where we don't remove the uterus, but we just, like during a laparoscopic surgery, are using energy to, again, kind of like destroy the fibroid by just poking into the uterus and doing that to the fibroids themselves, which is an option. That's very new and only exists in a certain locations in Colorado. And then in terms of kind of real surgeries for fibroids, there really is hysterectomy and myomectomy. Myomectomy is, again, it is a laparoscopic procedure where the goal is to go in and just remove the fibroid or the fibroids from the uterus and then repair the uterus and save the uterus. That's a myomectomy. So So myomectomies are great, and they are great procedures for certain women in certain situations, but it really depends a lot on the size, the location, and the number of fibroids that a woman has as to whether or not a myomectomy is really a good feasible option for her. There are some types of fibroids that really lend themselves well to myomectomy. There are other situations where there are too many, too large fibroids that are in the wrong locations where that surgery can become really difficult and a little dangerous to try to do a myomectomy. And there are situations where a hysterectomy actually is honestly, I believe, a safer procedure for that person than a heroic effort to try to save the uterus, even though I'm on board with that idea. With prolapse, I've given a couple other lectures here about pelvic floor stuff and prolapse, so lots to say about this, and I wish there was a longer list of interventions for prolapse that are not surgery. But prolapse surgeries exist. They commonly involve hysterectomy. They are great procedures, but the things that we have to do before surgery for prolapse is really a discussion about like how can we try to fix this ourselves? How can we do pelvic floor strengthening, pelvic physical therapy to strengthen our pelvic floors as much as possible? So maybe symptoms are better, prolapse is better, maybe we don't need a surgery. And then secondly is the idea of pessaries. And the pessaries, if you've never heard of that before, might sound really weird, but these are vaginal inserts. They come in many different shapes and sizes where we find the right pessary for the patient that does really hold the prolapse back up and support the prolapse in a way where they really don't feel like they have prolapse anymore. And they really don't feel the pessary if it's the right pessary for them. So that can also be a non-surgical, long-lasting solution for prolapse that doesn't involve surgery. And pain and endometriosis, lastly, they're very complicated problem. Also gave a talk on that just a little bit ago. There's definitely a place for managing the pain without anything else with endometriosis, and that's some variety of pain medicines, anti-inflammatories, that kind of thing. There are hormonal medications that can really work to improve endometriosis pain and symptoms. That can be something like a birth control pill. There are also other different medicines that can really shut down endometriosis and endometriosis pain, one of which is Orlissa. And then there are diagnostic laparoscopies and surgeries where we can go in and identify endometriosis and remove it, but not do a hysterectomy, not have a plan to remove anything else other than just treating endometriosis. So there are kind of less invasive procedures that treat endometriosis too. So why might we choose hysterectomy or a bigger surgery if not those other options? And you know, this is a process, and it's a discussion with your doctor, and everyone is truly different, as you might expect, about like how they feel about surgery, how they feel about what they've learned about these less invasive options, where they're at in their life. You know, I think the decision to have surgery, it is a big deal, and I think people get there in their own way, and hopefully with their physicians really kind of like giving them all the information so they can make smart decisions about that. But you know, if I was going to put bullet points on it to say that the less invasive options have not worked, they have not alleviated the symptoms, that the less invasive options are contraindicated, that they're not safe, they're not right for that person for one reason or another, that there are no other options that are available to us, or that the patient and the surgeon have a good conversation about this, talk about risks and benefits, which is what life is all about all the time anyway, and that we make a shared decision that surgery is the right thing for them at that time. And that is good and fine, and it can be like that. It is indeed not even really is true in this day and age. I'm happy to say that patients are made to jump through every lesser hoop before they have a hysterectomy. I don't really want anyone to just jump to a hysterectomy right off the bat, but it isn't true that there's that many rules for the patient. You know, it's really just about talking about options, talking about risks and benefits, and making the decision that's best for the patient. So just to talk about the surgery and what it's like to have the surgery. a brief comment about how we do hysterectomies. So I think people might be aware that there is more than one way to do a hysterectomy. The oldest and still a very good option is the idea of doing a hysterectomy vaginally. So that might sound surprising if someone wasn't aware that we could do it that way, but it is definitely true that many hysterectomies can be done just through the vagina and with no incisions in your belly, and the whole surgery is done that way. So there's a vaginal hysterectomy. There is an open or an abdominal hysterectomy, which is most often using a C-section incision and actually very much the same as a C-section incision to do the hysterectomy just in an open way through the belly. And then there are laparoscopic hysterectomies, and robotic surgery is really a fancy subset of a laparoscopic hysterectomy. That is a tool to do laparoscopic surgery better. And the choice for what mode and modality gets used to do a hysterectomy is important, and it's very important how it relates to the surgeon that you're talking to, because there are pros and cons to different approaches on how to do a hysterectomy. But it is also super important what your surgeon, and I hope you have a good relationship with your surgeon and you trust them, the modality that they are most proficient at and most practiced at, and they have the highest number of reps with. Because while techniques can kind of be juxtaposed and compared, the surgeon also really matters, and the surgeon's comfort with that modality really matters. So it's important in total to think about, like, what are we trying to do? What other risk factors are present? And by what are we trying to do, I mean, are we just removing the uterus? Are we interested in looking for endometriosis and looking for scar tissue and adhesions, looking for other causes of pain? Because it is true that a vaginal hysterectomy can be great in a lot of ways, but it does not allow the surgeon to really look inside your belly accurately. And so for instance, there are many other cases where a laparoscopic approach is much better, because we really want to be able to look inside your belly. We want to really know more about what's going on. So what are the goals is a very important question. What other risk factors are present in the patient? You know, for instance, a vaginal hysterectomy can be a good option for patients who don't have large fibroids, who have not had a lot of other surgeries before. But if someone has multiple large fibroids and they've had 2 C-sections, you know, it may indeed be a safer procedure to do that laparoscopically so that we can more see what we're doing. And so, yeah, safety, and then what is the surgeon most comfortable with? And it is true, as this next slide kind of gets to about modalities of surgery, is that there is an evolution of how we are doing these surgeries. And even though vaginal hysterectomy is a good surgery, it is done and trained on less and less by trainees as they're in training, and it is done less and less in the world because laparoscopy has come so far and now robotics have come so far. So there is a phenomenon that the safety and the utilization of these modalities changes over time. And I think it is the truth that vaginal hysterectomies are largely being replaced by laparoscopic and robotic hysterectomies. But I think there might be some good stuff there. I think robotics adds a ton of benefit and safety, and I think there's a reason that has really occurred like that in the world. And it's true that robotic surgery, not only in gynecology, but in general surgery and urology, orthopedic surgeons are using a lot of robotic surgery in what they do. Digital and robotic surgery is adding a ton to surgery and is being taken up rapidly. So I'd like to just talk about the experience of it all and kind of how I describe the whole thing to the patient, kind of when I go through this in the office. So in terms of preoperative experience, you know, this involves usually a couple conversations, at least, between the patient and myself talking about options. It is very often important and interesting to think about getting imaging tests like a pelvic ultrasound or something like that about what's going on, why is this going on. Obviously, the workup changes based on the problem at hand. But we always then have a pre-op visit in the office where the surgeon really just says this whole thing to you about like what is going to happen, what's the day going to be like, where to show up and when. There is not really hardly any preoperative prep funny business that goes on these days. We don't do bowel preps before hysterectomies. Really, one of the only things that happens is that we just need you to stop eating at a certain point prior to having surgery the next morning. So I think bowel preps is kind of, or like major restrictions is kind of a question that comes up about preparing for surgery. And there's very little of that, to be honest. We just need you to stop eating the night before. So the hospital experience, they will have you show up to the hospital usually 90 minutes early. You can bring your loved ones with you into the pre-op room while you'll be hanging out prior to the surgery. Your surgeon will come in and talk to you. Well, they'll give you a gown. They'll start an IV. Your surgeon will come in and talk to you and make sure you guys don't have any last-minute questions. Your anesthesiologist will also come into that first room and introduce themselves and talk to you about how they're going to do anesthesia. They will ask you about experiences you've had with anesthesia in the past so that they can modify the regimen to hopefully reduce nausea, if that was there before, or other symptoms that you had when you woke up. And then off we go to the surgery. It is true, as part of the medicines that you get as part of anesthesia, patients very rarely remember any part of the operating room. And they weirdly typically forget about half the post-op room and half the pre-op room in a retrograde fashion. So I don't think patients very often have a lot of memory from the OR itself. A hysterectomy, on average, even though this varies based on what's going on, but may take 90 minutes, I think, as an average, 60 to 90 minutes. And just to talk in general terms about what goes on with the actual surgery, the patient is kind of laying flat on the operating room table. They tell you to picture the beach and you're off to sleep. They clean off your belly. And indeed, with what I'm going to describe here as laparoscopic hysterectomies, which is the way that the vast majority of these are done. And again, that includes robotic hysterectomies. That's just a type of laparoscopic hysterectomy. We start by blowing your belly up with gas, which creates space inside your belly to move around. We make small incisions in your belly. These incisions with laparoscopy a traditional laparoscopy are 5 millimeters. With robotics, they're 8 millimeters. They're about as small as we can make them. And for laparoscopic surgery in the pelvis, you will have typically 3 or 4 of these small incisions, one in your belly button, and then lower right, lower left, and occasionally additional incisions. And through one of those ports is a skinny camera with a light on the end of it. And then we are looking around inside your illuminated belly, your open illuminated belly. And we do take a moment to look around the belly, take pictures of other organs. It is a unique opportunity to be in there. And then we're focused on the pelvis for the rest of the surgery. And the surgery is done typically just using cautery and cutting. And so there are not typically clips or staples or any permanent materials that are left behind when we do these surgeries. There are ultimately dissolvable stitches that are used at the top of the vagina if the cervix is removed. And then there are dissolvable stitches on your skin that close these incisions, which do indeed go away on their own without needing to be removed. Under most circumstances, patients have a catheter that's put in, a bladder catheter that's put in after they were asleep, and it's taken out before they wake up. And then they go to the recovery room without a catheter. It's usually an hour of initially waking up and having juice and crackers, and the nurses that are there have pain meds available to you to kind of try to get you comfortable as quickly as possible when you wake up. And then if patients are going home the same day, and it is an important thing to say here, most laparoscopic hysterectomies these days are outpatient procedures. So this is one of many things that's a little bit different than our grandmother's hysterectomy experience, is that I think this perception that we might need to use a large incision for sure, and that it would be a long surgery with a lot of anesthesia, that you would be in the hospital for a few days, and it would be 6 weeks of slow recovery is not the experience of hysterectomy anymore, I'm happy to say. So indeed, many hysterectomies are actually outpatient in a way that I think is good and safe. I think patients are feeling good enough to be home and sleep better in their bed and are really not in the hospital that long. And so ultimately, after you go home, once you're ready to go, you'll have very clear instructions about home, what to expect, how to use Tylenol and ibuprofen, which for a lot of patients is indeed almost all we need. It is actually not only possible, it's very common to not need any narcotics after these surgeries. It definitely can happen that patients do better and feel better by using a small amount of narcotics, maybe for the first couple of days after the surgery, but many do this without those opioids, which is fabulous. We are on board with that. But we also don't want people to suffer and not be able to rest. So, if at all, opioids are used very sparingly after these surgeries, and often not at all. But I think the post-op recovery experience, and again, I have to talk about this just on average. No two surgeries are exactly the same, and no two patients are exactly the same. So I just kind of want to provide an average experience if I can. I think the day of surgery and perhaps the next day is really the time when patients are feeling a little weird, mostly from anesthesia. It's a lot of strange drugs in their system, not sleeping super well that night. And if there's a time when there's more pain, I think it is that those first few days, just those first initial days after the surgery. But I do think that a lot of patients, just come back and report to me that what they experience is day by day within that first week, feeling better and better, being more mobile, up and moving, and that their pain is less and less every day. I ultimately see patients at 2 weeks and 6 weeks after those surgeries. And it is the truth that it's very common at the 2-week visit for patients to be feeling pretty good. Not perfect. This is not a cakewalk. I don't want to act like it is, but patients at the 2-week visit are very commonly feeling happily like they've turned a corner. They're feeling pretty good. They're certainly not on opioids and are tapering off their other medicines. They're curious if they can do more walking, hiking. And at 6 weeks, I hope that almost all of them feel very good. So, and I think there are obviously differences amongst patients in terms of how that timeline goes, but I think the vast majority of the healing experience feels like it happens within 2 or 3 weeks for most patients. So I think that's better than most people expect, and I'm happy to say I think that happens the vast majority of the time, which is good. So just to talk about outcomes and benefits, there's a lot of ways one could look at the outcomes, symptomatically. Are you happy with this from surgery? But a lot of the studies use patient satisfaction, how do we do on symptoms, and also psychological and sexual parameters. So I have a couple of studies here and then a summary, and I don't want you to just take my word for it that people say that they're better afterwards, but patient satisfaction scores after hysterectomy are very high, objectively. And these are metrics that these studies are easy to do. Take a time point like this study did at 12 and 24 months and follow patients and ask them these questions. So at 12 and 20, and this was 1,300 women having a hysterectomy, all comers. And I'll see if I have my little laser pointer. So I'm just following these results here. 12 and 24 months after hysterectomy, 95%, 96% reported in this. So that's 12 months and 24 months is what these pairs of numbers are. 95%, 96% reported that the hysterectomy had completely or mostly resolved the problems or symptoms they had before the surgery. 93% and maintained a year later, 93% reported the results were better than or about what they expected. 85% and 81% reported that their health was better than before the hysterectomy, and 87%, 93% reported being totally recovered. The factor that was most strongly associated with not being happy with outcomes was needing to be readmitted to the hospital with a complication, not surprisingly. A similar study that was just trying to comment about patient satisfaction looked at 257 women that were followed for 3 years after hysterectomy. Pelvic pain, abdominal pain, depression scores were reduced in the 3 years after the surgery. This is an important point. 21% of the women in the first group, and that first group did not have ovaries removed, 43% did, regretted the loss of fertility. And I do want to acknowledge that. I think that is part of one of the hardest parts about this surgery is that fact, for whatever it is. But even with that being true, the satisfaction, the patient satisfaction with the operation was greater than 90% after 3 years in both of those groups. And that the incidence of new pain due to adhesions or any other reason was low, 3% in one group, 5% in the other. So other studies have been done like this about symptom relief. There was another study done in that same cohort of women. There's 2 studies that were kind of done in that same group, 1,300 women who underwent surgery for benign reasons. In total, substantial reductions of symptoms, which I have a graph on this on the next slide. Substantial improvement in symptoms that persisted at 2 years following the surgery. 96% of patients ultimately indicated that the surgery had somewhat or completely resolved the symptoms for which they underwent surgery, which I have to say is good, you know, and I think one might expect that if someone had very heavy periods and we removed the uterus, you'd be like, no, duh, okay, I believe that you improved that symptom. But this study included women with pain, with fibroids, with bleeding, you know, and that number of somewhat or completely resolving their symptoms, which are often significant when women are coming into their doctor to talk about hysterectomy, is a huge number. So, you know, I don't know if that is surprising or not to people, but hysterectomy is very effective in terms of patient satisfaction and symptom relief. Objectively, I do think it's true. This is a graph that talks about symptoms. And, you know, these indeed are relevant and common symptoms for which women might look into a hysterectomy on the left there: vaginal bleeding, pelvic pain, back pain, activity limitation, sleep disturbance, fatigue, bloating, incontinence. And when you are just looking at before surgery and after surgery there on the right, they are dramatic improvements. You know, as I said, not surprising the vaginal bleeding is effectively fixed by hysterectomy, that number drops to less than 1%. But these other metrics are really important, impactful symptoms to have in one's life. You know, pelvic pain, back pain, limited activity, disturbed sleep, you know, chronic fatigue. For those numbers to drop from 63% to 8% and 43% to 17%, and a 60% activity limitation, which is an activity and sleep in a holistic way. We have to preserve those in life. We need to be moving and exercising and sleeping as well as we can to be happy, healthy people. And to have a reduction in activity limitation from 60% of patients to 2% is incredible. It's great and it's important. So, you know, in all of these metrics, I think really good symptom improvement. And I think one thing that I just want to touch on briefly that underlies a common reason that women have hysterectomy is anemia. So as I said, heavy bleeding is very, very common in terms of a reason to be talking about a hysterectomy. And anemia, I think on the surface, people kind of get that. We're having too much blood loss and like my blood counts are low. And some symptoms of anemia are quite obvious, perhaps feeling tired, occasionally being dizzy. But I think it's true that I think it's sometimes hard to really appreciate what a profound effect chronic anemia and your body chronically working on addressing this anemia all the time in the face of rather constant bleeding, what a task that is for your body, and to what degree that does impact your sleep, which is a big deal, and your cognition, which is a big deal. and your exercise tolerance so that you can get to the gym and feel good doing it. Anemia has a significant impact on all that stuff, and I think sometimes it's not always obvious to patients to what degree that's affecting their life. And I must admit, I do hear about patients having these experiences of these fringe benefits that they weren't actually quite expecting after the surgery. I think a lot of those come from addressing chronic anemia. So, and on terms of the sexual outcomes, this has been studied about 6 ways from Saturday. They do a lot of studies on sex, and I'm really happy to say that hysterectomy in total is really unlikely to cause sexual problems later in life. And if anything, probably improve. They've seen neutral to positive incomes in terms of sexual function following hysterectomy, regardless of whether we remove ovaries or not. So in terms of potential complications, the acute things that can happen in the operating room are bleeding, accidental intraoperative injuries, urinary retention after the surgery, and us needing to switch to an open surgery from a laparoscopic approach. These are all really important complications to talk about. I'm happy to say that they occur very rarely in uncomplicated hysterectomies. And there are a separate group of complications which also have very low incidence rates that happen in like the delayed time after healing from the hysterectomy, like continued issues with bleeding, infections like bladder infections, skin infections of your incisions or other infections in your belly. And particularly importantly, an unrecognized serious injury presenting itself later is probably the thing that we are perhaps the most sensitive about and really want to avoid, because that really, it leads to bad outcomes and bad experiences. So, and this is just another study really looking at those incidence rates of bleeding, complications, pelvic floor disorders, infection, all in the 1% to 2% range in the largest study I could find of 80,000 hysterectomies being followed over 23 years. So in the time I have left, I kind of want to really try to buzz through common questions and answer them quickly, and then get to your questions. And hopefully that encompasses a lot of good questions about this. So this is the list in total. I will go through all those. Will this surgery necessarily involve a C-section incision or an open incision? And the answer is usually not. There are, and this is obviously important to have a surgeon that does laparoscopy and is comfortable with laparoscopy or vaginal hysterectomy. But for me, there are rather rare situations where we would need to do an open surgery. That is, in my experience, in my practice, is almost only for patients that have really very large fibroids, very large, where there's really not even enough room in their belly to do laparoscopy. So many procedures can be done laparoscopically with small incisions. Another very common good question, these are common ones I get in the office. Are we gonna remove the cervix? Do we have to remove the cervix? The answer is no, we do not have to remove the cervix. There is a type of hysterectomy where we do not remove the cervix. We actually just remove the top of the uterus that kind of does the bleeding. And I have a picture about what that surgery is like on the next slide. But the reason that patients are often asking about preserving their cervix, which is a perfectly good question, is that they are often worried. Well, one, they just might not want to lose any other body parts, which I totally understand. But they're particularly from a symptom standpoint worried about, is it going to impact sex, removing the cervix, or is it going to predispose me to prolapse because you're messing with my pelvic floor support? And I do think that these questions, which are good ones, have been really confidently answered in the research about not removing the cervix does not negatively impact sex, and that removing the cervix during a hysterectomy, when that surgery is done well, should not predispose a woman to developing prolapse. So I don't think those questions should change a woman's decision to remove the cervix. And just to describe that, there is a type of surgery called a supracervical hysterectomy where we just remove the top and leave the cervix. So just to say 2 little words about that though, that surgery is ultimately done quite rarely these days because although I'm extremely open to the discussion and doing it every time, but I think the reasons that patients might want to leave their cervix are not really supported by the evidence. The worry about sex or prolapse, I'm happy to say that. And then secondly, there are some downsides to leaving the cervix, and that a woman still would need to get pap smears and still has the potential to get cervical cancer. And it is also quite common that women have endometrial tissue that's actually like within the endocervical canal, and so that we can actually remove the top of the uterus, but they still have light bleeding on a monthly basis from the cervix, which is quite annoying for patients that we're trying to avoid that. And this is just a Cochrane review that really looked at the question about sex or future prolapse with removing the cervix or not. And in these slides, you can kind of review some of these numbers, but not impacting major outcomes such as urinary, bowel, or sexual function, or complications or readmission rate or transfusion if we remove the cervix or not. And that when they follow these same women for 14 years, they didn't see a difference in pelvic floor problems. So I don't think there's a difference in sexual function or prolapse. So, but there is an important thing to acknowledge about this, that the question of whether or not just a hysterectomy in general, when we remove the cervix, would predispose a woman to prolapse is a good question. And to be honest, there is, I think, not a clear answer from the literature about this question. There are many studies that suggest that this does not occur. There are some studies that suggest that it can occur. I think the smartest people that think about this problem, which is what I agree with, is that there are very likely many factors at play here about someone's risk of prolapse after having a hysterectomy that have to do with some things that are about the patient without judgment, like size, other health conditions, fibroids, or other reasons they had the surgery. There's also a lot to do with how the surgery is done from our perspective in terms of incorporating pelvic support ligaments. And I do think that when these surgeries are done well with attention paid to pelvic floor support, and patients also are aware of this topic and perhaps are interested in doing pelvic physical therapy and keeping a strong pelvic floor after surgery, I think the risk of prolapse after surgery is truly low. But I have to admit that there is not a completely clear answer about this. So do we have to remove the ovaries during my surgery? Very common question. The answer is no. We do not have to do that just because it has to be done. It is always an option if we remove the ovaries or not during a hysterectomy. So a hysterectomy can definitely be done completely safely and effectively while leaving the ovaries where they are. But that touches another common question. Will this surgery affect my hormones even if we don't remove my ovaries? And I don't have time to kind of go through all these numbers with you, but the real answer to this question is that this is also quite unclear. And there probably is a kernel of truth in here that a hysterectomy with removing the ovaries definitely affects your hormones. The ovaries are what are producing hormones, and removing the ovaries has a dramatic impact on that. But even hysterectomies where we retain the ovaries, there are studies that suggest that it is not that all women go through early menopause or have different ovarian function, but I do think there's a kernel of truth here that there's some type of small insult that is there to the ovaries during that surgery. We don't exactly know why that is, if it's change in blood flow around the ovary, but there is a change in hormone production and a change in timing of menopause, as well as they're able to study these things. I would not say it's astronomical, but I do think it's real. So I think that this is an important one to talk about with your surgeon too. So will this be a long, drawn-out recovery? I don't think so. And I say that happily and confidently. I think when these surgeries go as planned, I think patients are usually quite impressed with their recovery. That when they talk about the average return to normal activities after a laparoscopic hysterectomy, they talk about 13.6 days, which I think the way you define that is a little bit all over the place, but I think that sounds directionally correct. Will I be in the hospital for many days? No. Most patients are done most surgeries are done outpatient, where patients leave the same day. It is always covered by your insurance to stay overnight one night in the hospital. So sometimes that happens for various reasons. And we're not tied to that one way or the other, but most patients do go home the same day, and they're feeling well enough to go home the same day. And lastly, will I need opioids for a long period of time afterwards? No. I'm happy to say many patients don't need any opioids, and we really just stay very regular with Tylenol and ibuprofen. That we don't need them at all. And lastly, although it might not seem like it perhaps all the time with how much you hear about surgeries and opioids and bad outcomes, we as surgeons and the environment around the OR, we really are interested in minimizing opioids, getting people up and moving, shortening recoveries. And there's a lot of really good work and research that's done on how to really improve the surgery experience for patients. And this enhanced recovery after surgery, or ERAS, is something that's been adopted here at BCH. It's been adopted around the world. That has many interesting, fairly progressive ideas about how to improve the surgical experience for patients in the pre and intra-op and post-op time periods. And I think this is making a big difference in how patients experience this. So I hope I've left a little bit of time for questions. Sorry to say a lot very fast there, but I do want to reiterate that this surgery is very common. It's very common. I think it's very common for good reasons. I think that, as you might expect, not a lot of patients are just jumping into this for no reason. These are really affecting problems that lead women to talk about this, and the surgery is common and effective for dealing with them. But it is really important, even though I think it's very likely to have positive outcomes regarding symptoms and quality of life. I think it's these conversations that you have with your surgeon are super important about how they do this, what are their outcomes, what are my risks following this procedure, given my individual situation. It's really important discussion. So hopefully I touched on a few components of the whole thing for you guys here.
Thank you, Dr. McNamara.
You're welcome. Thank you.
We're going to jump right into questions. Do you recommend that all patients work with a pelvic physical therapist following a hysterectomy?
My real answer is yes to that. I think pelvic PT is fabulous and way underutilized for following childbirth and also following any pelvic floor surgery. And even though hysterectomy is sometimes not thought of as prolapse surgery necessarily, a hysterectomy is a surgery that very much involves your pelvic floor. And we, as you heard me say, we really want you to have an excellent, strong pelvic floor as you heal and as you go on. So the answer is yes to pelvic PT for sure.
Great, thank you. How are uterine ligaments managed in the surgery? Are they removed or reattached elsewhere?
So they are reattached, I think is if I understand what that question is trying to get to. Uterine ligaments, particularly the ligaments that are preventing prolapse, these pelvic support ligaments, there are the two primary ones that prevent prolapse in the future, even though the pelvic floor is quite complicated, but the two main ones that prevent that are connected to the cervix. They're called your uterosacral ligaments. And during a hysterectomy, where we remove the cervix, those ligaments are interrupted. But then when I said that it is important for the surgeon to do hysterectomies in a way that tries to prevent pelvic floor problems in the future, to answer your question, yes, we want to incorporate those uterosacral ligaments in the way that we close the cuff or finish the hysterectomy, so that your pelvic floor as a unit is still supported by those same ligaments. So yes, and we do incorporate that in how we do the surgery.
Okay. How many hysterectomies do you perform in a year? And of those, what percentage is with the robot?
Yeah. So for me, as it is currently, I will often do 3 hysterectomies when I'm in the OR in an entire day, and I'll have those days 2 or 3 times a month. And so I multiply that by 12 is what I'm currently up to on that waxes and wanes, but that's what I'm doing every year. And the vast majority of what I do for hysterectomies is done robotically. I think I was lucky to be part of a group of trainees that was able to train with robotics right from the start. I really believe in it for the surgeon and the patient, and I think it really adds a lot for all of us. So I do a lot of them, almost all of them robotically.
Okay. How is the uterus extracted in laparoscopic surgery?
Yeah.
Is it pieces?
So if a good question, and there's nuance to dive into with all this stuff, but if a uterus is a normal size and small, and we're doing the surgery the way that we usually do, where we do remove the cervix, the way I describe this is that there is a moment in time during the surgery where the uterus is disconnected from everything that it was connected to. There's an opening in the top of the vagina. where the cervix used to be, and the whole uterus actually comes out through the vagina, which might sound really weird, but your incisions in your belly are very small. And so that is a completely safe and good way to remove the uterus. And then that opening in the top of the vagina, we close with strong dissolvable sutures that do dissolve, but they take a long time to dissolve. So most uteruses are removed through the vagina. There are some uteruses which are very large and very large with large fibroids. And it is true that to do that surgery laparoscopically with small incisions and to remove a very large uterus through the vagina, that is also the way that we do that. But we do that in the protection of a bag by indeed cutting it into pieces so they can remove it piece by piece. There's a lot more to discuss with that particular question, but we do still try to remove them vaginally by cutting it into pieces, but we do it in a safe way.
Okay. Do you see any hysterectomy issues for women taking Coumadin?
Coumadin?
Thank you.
Yeah.
Coumadin.
I think that can be done safely. So there are a lot of humans on Earth that are on blood thinning medications, whether it's Coumadin or Eliquis or any of this stuff. And so I think surgeons are very invested in working with your hematologist or your other doctors to have a plan about how we manage your anticoagulation around the time of your surgery. And there's a lot of ways to do that, and there's a lot of safe ways to do that. So yes, we do that.
Does the gas put in the belly during the laparoscopic surgery cause post-operative pain?
So it can, yeah. There is a phenomenon that's associated with this gas and gas pain. With laparoscopic surgery, we do fill your belly up with gas. It is our goal, and a whole step of the procedure is to try to let out all of that gas at the end of the surgery. And we try our hardest, but there is sometimes some small amount of gas that's left in the belly. That gas does ultimately just absorb into the body in a way that's safe. But if there is a small amount of gas left behind, that gas is irritating to the diaphragm in particular. And there is it honestly is a weird phenomenon that when our diaphragm is irritated in life, we feel that pain typically in our right shoulder. There's a referred pain. And so it does happen that patients will have this neck and shoulder pain for a couple days after laparoscopic surgery that's related to the gas pain, as people say. That is not dangerous and will go away, but it is an annoying feature that sometimes happens.
Okay. Can partial hysterectomy prevent uterine cancer?
It can. Okay. Yeah. A lot of nuance to that question, but to answer it shortly, if we are talking to someone who's concerned about or at risk for uterine cancer and you're performing that surgery before you developed uterine cancer, it is preventative of that cancer to remove the uterus. Yeah.
Okay. Is it true that the uterus supports the bladder and hysterectomy increases the chance of future urinary issues?
So good question, and not a clear answer to that. But the uterus itself does not quite support the bladder, but the structure of the pelvic floor, which is affected by hysterectomy, does. So this goes into, I think there is a kernel of truth here. I think it is true that the incidence of urinary issues and incontinence and bladder problems is very low following a hysterectomy, but I think there is a signal there. I think there is a small increase in that risk. And as I said, I think that risk is variable for person to person in terms of their pre-existing risk for prolapse and pelvic floor weakness. I don't think a hysterectomy helps that person who is already at risk for that necessarily. But I think what's important about that is to have a surgery that's done well and to talk about this issue around surgery and to work with pelvic PT afterwards. I think most patients can really not have that outcome occur, to be honest, if they work on strengthening their pelvic floor after surgery.
Great. Okay, we'll take a couple more questions before we close it up for tonight. What supplements would you recommend to treat menopause symptoms following total hysterectomy?
Yeah. So I assume there's also, I probably could have had a slide about weird terminology about hysterectomy, but if the term total is suggesting removing the ovaries, I do think there are, so big conversation about hormone replacement therapy, a lot to say about that. I think a lot of our providers and a lot of OBGYNs in general are very warm towards hormone replacement therapy. I won't speak for everyone, but I think a lot of us are. And it is true that the gold standard treatment of hormonal menopause symptoms after we remove your ovaries is hormone replacement therapy of some form, in the form of bioidentical options of estrogen, maybe progesterone. Those are and have always been the most effective options at treating menopause symptoms. HRT is not the only way to do that. There is a whole discussion about non-hormonal herbal supplemental options that can help with menopause symptoms but are not hormones that we can have, because that's a big one. But yes, there are hormonal and non-hormonal options to treat symptoms of menopause, whether it's natural or due to ovaries removed.
So on average, how long, in your experience, how long will it take a patient to be able to move around and do something like walk around the block after a hysterectomy?
I don't want to overpromise this, but the answer is very quickly. I would expect patients that were otherwise normally mobile to be able to walk around the block very quickly, as in within days of surgery. We don't advise or experience bed rest with any of these surgeries, and I do tell patients the truth that I think they'll be able to really, even if it's slow, to be able to walk and do stairs immediately after the surgery. And it's good to get out and get some sun and move around. So I think it's really quite quick the patients are able to move, to be honest. And I want them to.
Yeah. Okay, one more. Would a history of cancer, particularly lymphoma and endometriosis, be examples of needing open rather than laparoscopic surgery?
I don't think so. So lymphoma itself, I don't think so. And knowing that someone has endometriosis, perhaps from prior, if there's a suspicion of endometriosis and someone's never had surgery for it before, I don't think that at all precludes a laparoscopic surgery. Indeed, I do a lot of just endometriosis surgeries, and I would like to do all those laparoscopically as well. I think if we know that someone has a lot of scar tissue in their belly from having endometriosis, maybe that's known from a prior surgery. I think that is one reason we might take a little bit more time to talk about an open option versus a laparoscopic option. But to be honest, I think the vast majority of those would still be done laparoscopically.
Thank you.
Yeah.
We've come to the end of our time, and a couple of things. A recording of tonight's lecture will be available at bch.org/livestream, and tomorrow you're going to receive a post-lecture survey by email. We ask that you do please take a minute to fill this out. And I want to say have a good night, but Dr. McNamara, do you have any, a closing statement you'd like to make?
No, I appreciate people tuning into this. I know that just having a lecture about kind of a scary surgery, I think is probably a little confronting a little bit, but I appreciate people being curious about it, because I just want patients to have more good information about this so they can make good decisions. So I appreciate you tuning in. This is my main message.
Thank you and good night.
Thank you.